Okay, let's move on to the next. I think,
So we have Dr. Karthikeyan. I'll
yeah,
be sharing his presentation on his behalf.
yeah, Dr. Karthikeyan, please go
Yes,
ahead.
sir.
Lovely to have you. So,
Thank you, sir.
this is a
Thanks again, sir.
platform for all young, aggressive, proactive, interventional cardiologists, and we keep sharing such beautiful cases with the message. Go
Yes,
ahead.
sir. Yes, sir. Good afternoon, everyone, and special thanks to Dr. Rajneesh, sir, for providing this wonderful opportunity. And my topic for today is breaking barriers, the calcium conquest. Next slide, please. So, our case is that 73-year-old male with multiple comorbidities who is known diabetic, hypertensive, hypothyroid on medications actually. So, a patient experienced exertional chest pain for 3 months, for which the patient was evaluated outside actually. They did an angiogram where they found the patient had a calcific triple cell disease. So, PTCA to RCA was attempted, but the lesion was balloon non-crossable. So, the patient procedure was deferred and the patient was referred to our institute, sir. So, after discussing with the patient, we went ahead with a planned PTCA to RCA, and we chose right femoral, arterial, and as well as venal access. Next slide. Uh, so, as we can see here, kindly play all the videos, please. As we can see, the patient has a severely calcified mid-RCA significant lesion. We can clearly see the two orthogonal views. So we went ahead and crossed the lesion with the rotablator wires actually initially. Next slide. So we started with 1.25 mm burr with 1.5 1.8 lakh speed, then went ahead with 1.75 mm burr with 1.74 lakh speed RPM. Then the lesion was dilated with a 3 into 15 NC balloon actually. Next slide. So after the rota, we did the post-rota IVUS run actually. We can clearly see there is a presence of dissection and the minimal luminal area, the narrowest portion showed 3.48 millimeters square. And also we can also able to see the near 360-degree calcium mark which is present in the IVUS. So we thought this patient will require IVL before we go ahead with stenting, sir. So next we took the IVL. Next slide, please. Next slide. So we went ahead with 3.512 intravascular lithotripsy balloon and we gave all the pulses and the post IVL stenting to the mid RCA was attempted, but still the stent could not be delivered. So we further dilated with 350 NC balloon again and we stented the lesion. Next slide, please. Next slide. We stented the mid RCA with 3.5 into 48 DES, and post stent dilatation was done with 3.515 NC balloon at 24 atmospheres. Next. So after that, we went ahead with osteoproximal RCA stenting and post dilatation. We stented the osteoproximal RCA with 4 into 18 DES, and despite the quite aggressive dilatation, you can clearly see the mid RCA. There is still the area looks undilated in the angiographically. So we did an IVUS run. Next slide, please. So we did the IVUS run. In the IVUS, we can clearly see the proximal is well dilated with the MSA post stenting around 6 with no post edge dissection. So we accepted this result. Next slide, please. So we accepted this result and we thought we'll end with this rather than aggressively post dilating the lesion and land up in a problem. Next slide. So our take-home message is the maximal lesion preparation with proper calcium modification is required before adequately stenting the vessel. And even after stenting, if we find it is under expansion in the angiographically, if we are able to get a good result in IVUS, rather than trying to make it quite good, we should accept the result rather than landing up in complications, sir. Thank you.
Yeah, Karthikeyan, it's a lovely case. And I agree with that totally. That finally, if your MS are going, just stop there. Because that calcium will not expand more. You have done already everything. You have done rota with the 1.75 bar, and then you have done IVL, and then you have done multiple dilatations with the NC balloon at high pressures. So I think beyond that, it's you are calling a risk for yourself if you're going ahead further for perforation. But if MSs are good, that's what we finally want. That should be our final point. Very well done case. Yesterday only I was doing a live case for CAD conference in Mumbai. It was almost a similar case. It was a CTU, heavily calcified. I'll show it some other time. So rota, but then the arc of calcium was very heavy, so did IVL. So it's a rotatripsy. So it's a rotatripsy, which is a combination, and rota, is engaging the central calcium in the lumen, and then IVL is required to burst the peripheral calcium, and that's where we get a good stent expansions. So input from you, Karan, please go ahead.
Sir, in such cases, would orbital be better because they recommend in larger vessels?
I know.
Orbital
So
is more
yes.
deep, I think.
So for the sake of discussion, yes, Karan has raised a very good point. Now maybe orbital decalcifies the vessel in a better manner to give a better area, because it is orbiting in the vessel and trying to cover the more width, more diameter in the vessel, especially if there are nodules. But even if there are no nodules, like in these curves, so what
Yes,
happens
sir.
with rota,
The
especially on
Bluetooth device is ready to pair.
rota will only take the inner side where there is inner bias. Rota will only, even if it is 1.75, it's going to go over the wire. So wire is
Yes,
usually
sir.
biased on inner side. While orbital, actually is going away from this bias phenomena. It is orbiting. So that way, yes. And, I have done almost 50 orbitals now since the time it is launched in India, and it is much easier to use. Like I was saying, that you put a TPI here. So orbital doesn't require a TPI, although we always keep the venous sheath while do orbital, but we don't keep the TPI lead. Uh, so, and then there are other points, uh, saline and that cylinder of rota. So it actually circumvents a bit of other stuff which we do in the preparation of rota. It saves our time and gives a good decalcification in such situations. So that always is a point of debate, but that doesn't take away the very good job done by Karthikeyan and their cath lab.
Yes, sir. Definitely. Very good case, sir.
Well done, Karan.
Yes.
Well done, sorry, Karthikeyan, and we
Yes, sir.
move on to the next,
Thank you,
right?
sir.